AF ablation was initially developed for patients with paroxysmal AF, AF that comes and goes. And we know that AF ablation is a very effective treatment strategy for patients with that pattern of AF. As AF becomes more persistent, more long-lasting, AF ablation is still an effective strategy, but the outcome rates are not quite as good. And that's essentially a reflection of the fact that the underlying atrium is more diseased, it's more stretched, it's more scarred, the electrical mechanisms driving the AF are more complex. So historically, if someone had been in AF for several years, and we label that long-standing persistent AF, they might not be offered an ablation because at least the perception was that the outcomes were not likely to be good enough to justify the potential risks of any procedure. Yet there are still clearly some of those patients who are symptomatic or who are developing heart failure and who would clearly benefit from being in a normal rhythm. So one of the strategies that's been addressed to help that group of patients is what we call the Convergent Ablation strategy. This involves two procedures. It involves an initial minimally invasive surgical ablation that targets the outside of the heart, of the atrium, followed 3 months later by a fairly traditional endocardial AF ablation inside the heart. And we've now got very good data that the combination of these two minimally invasive procedures, particularly in this group of patients with very established, very long-standing persistent AF, actually leads to exactly the same outcomes as a traditional ablation in patients with paroxysmal AF. It's not a definitive cure necessarily, but it significantly reduces how much AF people are having, and in some people it really does seem to get rid of it. With a convergent AF ablation, there are two steps to the procedure, essentially two different procedures. The first procedure is performed by a cardiac surgeon under a general anaesthetic, but it is minimally invasive. The surgeon accesses the heart with a small incision under the breastbone and then has an introducer tool that comes in underneath the heart and eventually allows them to access this area behind the heart from the outside. So the surgeon then performs what we call an epicardial AF ablation, where burning is applied to this posterior wall of the left atrium from the outside in. That's the first procedure. 2 to 3 months later, patients come back for a second procedure done by an electrophysiologist on the inside of the heart. And essentially, what we're seeking to do is to complete the process the surgeon started by electrically isolating the pulmonary veins and the back wall of the left atrium. So the surgeon ablates from the outside, the electrophysiologist ablates from the inside. And the two things together lead to very good results in this group of patients with advanced atrial disease.